So we presented the results of our study where we are treating patients with relapsed refractory CD30 positive lymphomas with a novel cellular immunotherapy that consists of cord blood-derived allogeneic NK cells that had been preactivated with cytokines in the lab, expanded with feeder cells, and precomplexed with AFM13, which is a bispecific antibody construct, which binds CD30 on lymphoma cells on the one hand, and CD16A on the NK cells on the other hand. So patients received, while the cell product was manufactured over 2 weeks at our GMP lab, patients received lymphodepleting chemotherapy with fludarabine and cyclophosphamide to create a more permissive environment in the patient and increase the persistence of the donor NK cells in the patient. So 2 days after completing lymphodepleting chemotherapy, we infused the AFM13 cord NK cells to the patient. And because we had seen in the lab that AFM13 remained bound to the NK cells for a week, we gave 3 weekly maintenance doses of AFM13 on day 7, 14, and 21. And on day 28, we evaluated response to the treatment, and that constituted 1 cycle. So patients received 2 cycles. In each cycle, the NK cells came from a different cord. In each cycle, the patients received lymphodepleting chemotherapy again. And this is a study where we escalated the dose of the NK cells from a starting dose level of 10 times 10 to the 6 per kilo to a third level of 10 times 10 to the 8 per kilo. So the treatment, we saw that we enrolled 22 patients. All were very heavily pretreated with a median 7 prior lines of therapy. They had all failed brentuximab vedotin. 21 patients had received prior checkpoint inhibitors. The 1 patient who did not receive it was a patient with T-cell lymphoma, where these drugs are not common in their treatment. 2/3 of the patients had received a previous stem cell transplant, and they had all progressive disease coming into transplant. They had very advanced disease at the time of enrollment with a median 6 prior relapses. We did not administer any bridging chemotherapy between enrollment and study treatment. We saw that the study treatment was very safe. We didn't see any incidents of cytokine release syndrome, neurotoxicity or graft-versus-host disease of any grade. Infusion-related reactions were non-existent after AFM-NK infusions, and they were minimal after AFM13 alone, with only 5% of the infusions out of 112 so far causing an infusion reaction. We saw myelotoxicity expected from the lymphodepleting chemotherapy, but no cases of clinical neutropenic fever or bleeding. So really, we didn't encounter any dose-limiting toxicity throughout the study, and the 3rd dose level was found to be the recommended phase 2 dose. The treatment was very active, with out of 19 patients who have undergone evaluation response, we've seen 17 responses, of which 10 are complete responses. And specifically in the subset of 13 patients treated at the recommended phase 2 dose, we've seen 8 complete responses for a complete response rate at that particular dose of 62%. So of those 8 complete responses, 5 were seen after the first cycle, and 3 more had their partial remission converted to a CR after the second cycle. We saw that the donor NK cells persisted in blood for about 3 weeks with a rapid peak after infusion, and that importantly, they presented an activated phenotype with a greater expression of CD16, which is precisely one of the target for the AFM13. So when we give AFM13 after the infusion on the maintenance doses, it binds more the allogeneic NK cells than the patient's NK cells. So we are very excited with our results because it's it's a very remarkably safe treatment and highly active in a very heavily pretreated population.